I am a fellow. Well, I was a fellow, I guess. I graduated yesterday at the Walter Reed National Military Medical Center. And then Dr. Makita was my boss on this case. I'm in the military, so I have a disclosure that these views are my views and not that of the U.S. government. And then I have no financial disclosures. So this provides like an overview of what I'd like to talk about. If I saw someone who is a type 1 hyper-IgM syndrome carrier in my clinic, what would my thoughts be before the visit, during the visit? What would I ask them? What would their answers be that would drive my decisions? And then we'll go over an example case, and we'll find out if from Dr. Torgerson if I did the right thing. Then lastly, I'd like to talk about highlight what are the risks and benefits of this approach and what's to do in the most likely outcome as well. Just so we're all on the same page, we're talking about hyper-IgM syndrome type 1, and that's how I refer to it in the slides. That is the CD40 ligand deficiency, or the X-linked hyper-IgM syndrome, the most severe of the hyper-IgM syndromes. All right. So CD40 ligand, as you know, is important for communication between T and B cells. And type 1 hyper-IgM syndrome affects males, and it's caused by aberrant functioning. Both T and B cells are affected, and because of this, they have an increased predisposition to viral, fungal, bacterial infections, as well as autoimmune diseases and malignancies. And the convention is that carriers, the female carriers, are much less affected, if affected at all. There's not a lot of data on carriers, but there is some. So I want to start off with this published literature. This was published in 1994, you can see on the bottom right, in the Journal of Clinical Investigation. And this is a case series of 5 healthy carriers. They were described as asymptomatic, handled infections well, and they were all healthy in their adult years. And CD40 ligand expression was as low as 12%, so very low. And then what was described, here's their immunoglobulins. I've circled in patient 3 that IgA is low in red there, and then in patient 4, the IgM is elevated. So you can see there's some variance, not everyone's the same. But what's actually kind of reassuring is in that middle column, the IgG, which is maybe the best predictor of the B cell function, is actually normal. So at the same time, while this study is kind of reassuring, it's concerning, but also reassuring at the same time. Keep in mind these people who lived into adulthood. There is, however, a case of a symptomatic CD40 ligand deficiency carrier, and that is, this was published in 1999 in the European Journal of Immunology. So this is a 12-year-old girl with recurrent sinus infections and pneumonias. She did have low IgG, and her CD40 ligand expression was only 5%. And the researchers were able to prove that this was due to extreme lionization. So extreme lionization is X-linked inactivation. I prefer the term lionization because it gives credit to Mary Lyons, who is a British geneticist who coined the term. But briefly, females have 2 female X chromosomes. So most women have 2 CD40 ligand copies. However, in each cell, 1 X chromosome is randomly inactivated. This is normal. It happens in all women. Carriers are unique because they only have 1 good copy of the CD40 ligand gene. So they, like other women, also inactivate 1 X copy. And so you would expect a CD40 ligand expression of about half, 50%, especially in their T cells. So extreme lionization is when the same X chromosome is getting inactivated. And so this patient had only 5% CD40 ligand expression, and they demonstrated it was because of that. All right, I'm going to change gears a little because I want to discuss what I have in mind in the patient encounter. And I've heard Dr. Sergio Rosenzweig talk 3 times, and every time he's mentioned this study. So this was 2017, the Journal of Allergy and Clinical Immunology. This study looked at 278 families from 22 countries. All the patients had like a wide range of immunodeficiencies, and they all had severe enough diseases that they had an indication for genetic testing. And so on all these patients, whole exome sequencing was performed. Whole exome sequencing, just real quick, is looking at the DNA, the sequence of the DNA that codes just for proteins. Doesn't look at all the DNA, just the regions that are a blueprint for the proteins. In total, then, it looks at more than 20,000 genes, and its use is considered maybe a non-biased approach in evaluating immunodeficiency syndromes. And whole exome sequencing will find 85% of the pathogenic genes, or rather 85% of the pathogenic genes are found in the exome. So it's pretty sensitive, probably one of the most sensitive tests we have. But keep in mind, hyper-IgM syndrome wasn't the focus. But I do want to go over these results because it really affects how I work up patients. So these top bold colors, altogether those numbers add up to 40%. So in those patients, a likely diagnosis, a genetic diagnosis was obtained, 40%. The bottom two, which add up to 60%, no diagnosis was obtained. So the majority of patients did not get a diagnosis, despite very sensitive tests, a very thorough, very expensive test. But keep in mind, and this is what Dr. Rosenzweig highlights, is this 5% here. So in 5% of the patients, actually two pathogenic genes were identified, or two causative agents that were contributing to the patient's syndromes. Or said another way, if you had one genetic diagnosis, 10%, over 10% of those patients had a second genetic diagnosis. All right, so we'll get into more about how this affects my workup. I just want to go over their final findings. So they categorized into 10 different categories what the immunodeficiency kind of looks like, how it presented, and then based on that, the height of these bars are how many patients they had in that category, and then the blue is did they get a diagnosis. So here's someone with severe combined immunodeficiency. They had 10 patients, and all 10 got a genetic diagnosis. But you can see in the column right to the left of it, this autoinflammatory disorders, so very sick patients, very severe presentations. They had 15, and only 13% had a genetic diagnosis. So it kind of varies across presentation. And again, the hyper-IgM syndromes weren't the focus of this study. But I kind of want to summarize. So when I see a hyper-IgM carrier in clinic, I'm going to keep in mind, generally, the literature is reassuring that it's out there. There's not a lot, but it's generally reassuring. And then there is some heterogeneity described. Not everyone's the same. Lionization might affect their presentation. And then it's certainly possible to have multiple genetic causes of a presentation. Now, I should give you a caveat that not all physicians think that way. So the physician you're seeing in your office, commonly thinks, lightning doesn't strike twice in one area. Or for instance, if I took like a random person off the street, what's the odds that they have this 1 in a million disease and another 1 in a million disease? That's commonly how most physicians would think. I'm just giving you that heads up. Whereas I think, if you're the person who now has a diagnosis, then the odds of you having a second diagnosis would be higher, kind of like I've showed in that study. I could talk more about, like, if you're trying to roll 2 1s or something, well, the odds of getting that is low. But if you've already shaken a 1, now because they're independent variables, what's the odds of getting a 1 in your next shake? You can think of it that way. So taken together, though, whether that's controversial or not, essentially I would evaluate a type 1 hyper-IgM syndrome carrier the same as I would evaluate any patient, right, with the same care and the thought that I'd see any immunodeficiency patient. So with that in mind, I want to talk about when we should evaluate patients. So this is from the Jeffrey Modell Foundation. 10 warning signs of primary immunodeficiency in adults. There's another one for kids. But most docs do have this in mind because this is probably the most memorable and very iconic. So when should you worry about having an infection? And like I say, this is what's going to kind of set you apart from the general population. Because to be honest, every one of us, even myself today, last week, I was thinking, man, it's taken me a little while to get over this cold, and maybe I've got some small problem with my immune system. But so everyone thinks that sometimes, I think. But these are really what's going to set you apart. So one, do you have 2 or more ear infections within a year? For adults, like I said, not kids. 2 or more sinus infections, like true sinus infections in the absence of allergy in a year. More than one pneumonia, or one pneumonia more than once a year. It's kind of a guideline. Chronic diarrhea with weight loss, severe recurrent viral infections, the need for IV antibiotics to clear infections, recurrent deep abscesses, persistent thrush or fungal infections. Thrush meaning in the esophagus here, not just in the mouth. Infection with normally harmless pathogens, and then family history of primary immunodeficiency. So this is kind of what you can use to set yourself apart. And then when I'm going to talk to a patient, I'm going to ask them, because I'm trying to assess the same thing. I'm trying to assess, is this really a patient who's just telling me they're always sick, or are they really always sick? So I'm going to ask, hey, how many IV antibiotics have you had? Have you been hospitalized? Are there objective evidence? Is there objective evidence of infections? What are the causative organisms? Can I attribute the infections to something else? And then, is there early cancer or autoimmune disease? I always ask. And then, of course, depending on the patient's complaints, maybe this patient needs like another service, like a GI or something. Of course, I can always help with that too. So with that in mind, this is a 38-year-old female who presented to my clinic, and I'll walk you through how I did this case. She had a diagnosis of CMV hepatitis diagnosed by GI. All right, and that's why she was referred to my clinic. So already, for those of you who don't know, the CMV is typically asymptomatic. So she kind of is meeting one of those things on that list of 10. All right, then I'm going to ask her more questions. So I find out as a child she was hospitalized on 3 occasions for like a systemic urine infection, and then she had more urine infections as an adult. Now I took care to look up her urology notes because I wanted to see, is that because of her immune system, or is that because, maybe she just has a tough time clearing urine. Kids can have reflux of their urine. So I looked up and her studies, and they were normal. So it didn't look like she was having any problems with like static urine. Moving on, she had 2 to 3 upper respiratory infections a year, for which she had prescribed antibiotics. Now, imaging of sinuses did show 1 acute sinus infection that resolved with antibiotic administration. So the reason I put that in there is because you might go to a doctor and say, I get 5 antibiotics a year, but as we know, and as the infectious disease doctors will point out, like half of antibiotics are inappropriate, and a lot of like PCMs might just give you antibiotics for maybe bronchitis, like a viral bronchitis, or just because he doesn't want to risk not giving you antibiotics. So when I'm hearing, I get 5 or 6 antibiotics a year, I always try and go and confirm, and so that's why I looked up the CT sinus, or I looked up the imaging of the sinuses. So at least there was one, and obviously you don't have to get a CT every time, or an X-ray every time you have an infection, but at least there's some objective evidence that some of these are real sinus infections, because I'm more trying to gauge like the patient's the PCM, right? There's all sorts of the primary care manager, the primary doctor. There's all sorts of primary doctors. Then same thing with chest imaging. I'm trying to look for active pneumonias that were actually documented, so like an opacity on the chest film maybe, and there was a calcified granuloma, so maybe evidence of a prior infection. And then she had mastoiditis that was demonstrated on a CT. and then frequent several different types of Candida infections as well. So there's some infectious history there that definitely is more than the general population, and there's objective evidence. So that moving on, I asked about family history. Of course, she was a known CD40 ligand or type 1 hyper-IgM syndrome carrier. Her father had died at age 38 following a fungal infection following a liver transplant. She has 6 children. 3 daughters are known carriers, and 1 daughter has similar infectious history as well, but the other 2 carriers do not. So other medical history, as we become adults, this list can grow very long, but most doctors will probably just ignore most of the other history and just focus on the infectious etiology or the infections. And then physical exam didn't really point me in any one direction. So this is overly simplified, but now I'm going to do a lab evaluation. And so if there's viral and fungal infections, I'm going to look at T cells. If there's bacterial infections, I'm going to look at B cells. And then, of course, because I know she's a carrier, I'm going to look at CD40 ligand expression and binding. So looking at the B cells overall, there was a normal lymphocyte count. That's kind of the total lymphocytes. She did have an elevated IgM on multiple occasions, and the IgG was low normal. Now this next one, the polysaccharide response to Streptococcus pneumonia. So often we'll give people a pneumonia vaccine that has, like, Pneumovax has 23 different strains of Streptococcus pneumonia. And then we're seeing how many does she develop antibodies to. And in normal patients, or in normal people, that's 16 out of 23. So it was lower than the normal population, but certainly not 0. So at the same time, alarming and reassuring. And then also she had a low B cell count. We sent differentiation of the B cell subsets, so that's trying to say, does she have the memory B cells, the long-lived plasmid B cells, things like that. And the assessment was kind of limited by low number, but it looks like a normal proportion overall. So some alarming things with the B cells. With the T cells, so T cell level was normal, T cell proliferation, so that's looking at phytohemagglutinin mitogen. That is just a chemical that's in plants and is known to irritate T cells. So if T cells come in contact with that, they're going to replicate and attack it, and that's kind of the gold standard for T cell function. That's probably the most important test, and that was normal. Now I get this a lot, the third bullet there, where there was low lymphocyte stimulation with the tetanus and Candida antigens. So I say that is not a very specific finding. I get that in actually a lot of patients, and especially with the phytohemagglutinin mitogen being normal. I don't put a lot of stock in that, just because it comes back abnormal almost all the time. I think I've seen maybe one normal one. And I think it's based on, how soon can we get the sample to the lab, because this is a live functional study, things like that. All right, now the T cell demonstrated a 56% CD40 ligand expression. I did want everyone to keep in mind we are looking at the T cells, so I know CD40 ligand expression is sometimes reported differently if you're looking at, say, all the lymphocytes, but in this case, the Mayo Clinic had isolated the T cells and was looking just at T cells. So some people were talking about lower rates of expression. That might be because they're looking at B cells, the neutrophils, things like that. But anyway, 50% would be considered normal for a carrier, certainly less than the general population. But like I said, that would make extreme lionization unlikely. You recall in that first case, the expression was 5%. So that wasn't concerning. Now we did get whole exome sequencing because the history didn't really seem to match the type 1 hyper-IgM syndrome carrier status. and no pathogenic gene variants were found. But there was, and I'm going to talk more about this, what's called a variant of uncertain significance in a single copy of an NCF1 gene. So NCF1 is something that can cause CGD, which is another primary immunodeficiency going on at this, being talked about at the same convention. So a variant of uncertain significance is kind of, can occur if, that sequence doesn't happen a lot in the general population, or if it's predicted by computer models to maybe not be functional. And so sometimes it can be cause a lot of stress in patients, because they'll think, well, shoot, maybe it is bad, maybe it's not bad. In our case, because this is a well-described gene and there's a functional test, we were able to prove that this wasn't contributory. But oftentimes, you can't actually. Oftentimes, there's no functional test, and you can't say whether the gene is working or not, essentially. Now, keep in mind her CD40 ligand gene mutation was not observed because it was at a known splice site, so in between the protein coding regions. So it didn't show up on the whole exome that had been sequenced prior, so that was already known. But we weren't expecting her mutation to show up on this part. Okay, so just to wrap up this case, so in the setting of frequent infections, abnormal laboratory values, she was started on replacement immunoglobulin with the goal of decreasing bacterial infections. Because keep in mind, IVIG or subcutaneous IG cannot address the viral infections as much. So in the subsequent year, she had 5 courses of antibiotics compared to 8 courses in the prior year. So maybe some response. It's tough to tell with just one person, but she tells me she's feeling a lot better. Some questions certainly remain, though. Are her abnormal immune labs due to the hyper IgM type 1 syndrome carrier status, or some other undiagnosed thing? Combinations of variables are very difficult to assess. What's the best treatment? Was the ideal workup performed? So some questions still remain. All right, so keep in mind, all right, moving on, I just want to show this last study. So we talked about variants of uncertain significance. This is a study published in 2018 in the Journal of Genetic Counselors. They were keeping in mind that variants of uncertain significance happen 80% of the time with whole exome sequencing, so very common. They just looked at 14 kids from neurology clinics, and they were looking at people who did not have a diagnosis, but did have the variant of uncertain significance. And they called these people on the phone 6 months after giving them the result, because they kind of wanted they wanted the emotions, I guess, to settle in and ask them how they're doing. So I'll just point out only 6 out of 14 had a positive perception of the test. So that's 5 here who were relieved, and then 1 who was excited. But the other majority of the patients, 8 out of 14, were either stressed, anxious, upset, disappointed, confused, frustrated, emotional, or angry. So it can be, getting a whole exome sequencing could probably represent maybe a year of work for a patient. The first they have to get a PCM to send them to an immunologist. In our setting, we have to send them to genetics and then convince genetics. Then, plus you have to wait 4 months even to get the results. So it can be a lot of work, and it can be frustrating. All right, so I want to just kind of end with this conclusion. I've tried to talk about how I would approach a type 1 hyper IgM syndrome carrier, and really it'd be the same as anyone who comes to my clinic for concerns of immunodeficiency. Those are my thoughts. Those are the questions I would ask. So what can you do? Because you always want to say the important things, but not say too much where the physician just kind of stops listening. So the key things really, and I'll be very frank, if this patient had not come with a diagnosis of CMV hepatitis, I likely would not have done as thorough of a workup. So really, what you want to keep track of is, infections, objective evidence, the antibiotic use, misspelled frequency there. Get information on the causative agents, and then that's probably the most important. Then, if additional studies are obtained, I do expect a long diagnostic process in order to minimize stress. The reason for that is, because I am in the military, we talk a lot about chronic stress. Chronic stress is a big deal for us. You might have to move with your family year to year. You might have to deploy without your family. So stress for families, stress for service members, and just chronic stress can add. And so while I certainly think if you go down this diagnostic path, we could definitely get a diagnosis or improve treatment. But I also think, keep in mind that sometimes the most likely outcome could increase your risk for the stress. Like, for instance, if you get a variant of uncertain significance. And then I always tell patients, it can be good to be in this gray area sometimes. You don't want to have symptoms so bad that it's obvious what's wrong with you. So being in the gray area with this confusion sometimes is actually good. All right, those are my thoughts on that, and I think we'll take questions at the end. All right, thanks so much.